Hey guys, so I promised I would go over my sciatica post that I did for Physio Network this last weekend. So I'm going to go through those slide by slide. I'm going to kind of elaborate on the things that I wrote if any of you guys didn't understand it or if you guys had questions. Obviously, reach out to me if you have any questions after I do this post as well, and hopefully I can answer them so where you can understand them a little bit better. All right, so here's the post that I was referring to that I posted, I think, on Saturday. So when we talk about sciatica, or it's also called radicular pain or leg pain, about 60% of people have this. But what a lot of people don't realize is that any pain coming from the back and going down the leg does not automatically mean that the diagnosis is sciatica. Okay, there's other subtypes of back pain and leg pain, and that's what we talked about a little bit in this post. So in this slide here, we talk about 3 different subsets of nerve root pain, basically pain that comes from the low back deep inside here and then goes down the leg. So sciatica, also called radicular pain, that's the most commonly known one, but there's also radiculopathy and spinal stenosis. I'm going to go over those in a little bit more detail. So when people have radicular pain or sciatic pain, a lot of times the pain is worse in the leg than it actually is in the back. So people will complain of like butt pain or pain going on the leg. A lot of times this is confused for like piriformis syndrome, where it feels like the muscles in this area are the issue when it's actually coming from the back, but then you feel worse pain down in this area. A lot of times they'll feel it worse down in the lower part of the leg. So we talk about L4, L5, S1 dermatomal concentration. A dermatome is basically a map of what each nerve innervates, which area innervates. I'm going to show you guys a picture of that next. So this is actually a pretty good picture of that, and you can see like in the lumbar spine right here is represented by the green. So L4, L5, S1 would be this one right here, and the sacral S1. As you can see, L4 kind of comes on the outer part of the thigh, wraps around in like the outer part of the knee, and then kind of comes around the front. L5 also comes around here and then comes to the front of the foot down into this area. And then S1 comes more in the back. So people that have it more like in the back of their leg down towards the heel, it's more from that area. The other thing to know about dermatomes though is that dermatomes don't always follow this exact map. Maybe a nerve from one area of the spine is aggravated. It doesn't only stay in that region. Dermatomes have been shown to or nerve roots have been shown to cause discomfort in a variety of different areas of the leg, not just in the ones that are listed there, but those are some of the common patterns that we see, and it kind of gives us like a general map to kind of have an idea of maybe what area of the spine might be affected. So also on this slide it talks about that the pain is usually on unilateral or on one side. Most people with like a sciatica diagnosis don't have pain on both sides of the legs, although it can happen, but it's usually more on one side. And then the other thing is common findings that we'll see is nerve tension tests, meaning when we put this nerve on tension, or the nerves that come down the back of the leg, the sciatic nerve, those nerve tension tests will cause some discomfort. So the tests that it mentions here in the post are the straight leg raise and the cross straight leg raise. Those are going to put tension on the sciatic nerve. So straight leg raise means on the side of symptoms. So if this was my symptomatic side, a straight leg raise would be if you're laying on your back and a physical therapist or a doctor or somebody pulls your leg up passively, so you don't do it yourself, that someone just puts your leg up like this, and if you feel discomfort or your symptoms are elicited by that test, that would be a positive straight leg raise because we're putting tension on the nerves in the leg. So specifically the sciatic nerve that is from multiple nerve roots in the back and goes down the back of your leg. Now cross straight leg raise would be if we did the non-symptomatic side. So if this is my symptomatic side and we took my left leg and brought it up like this, that caused symptoms on my right side, that would be a positive cross straight leg raise. Now we also have more intense ways to stretch the nerve or put tension on the nerve, one of them being the slump test. I'm not the best angle right now, but the slump test would be, again, the patient would put their hands behind their back, or the person with the symptoms, and you would slouch down as far as you can, which puts tension on the nerves in the spine at this area, and then the clinician or the physical therapist would grab the leg and slowly bring it up like this, so there's tension all the way through the spine from here all the way up, even into the neck. So when I bring my neck forward, I'm actually putting more tension through all the nerves down the back part. And so I'll bring this up like this, and then if it brings on symptoms, that would be a positive slump test. Now, with any of these tests, you can actually change ankle position, you can change spinal position, head position, and that'll influence how much tension is in the system. Now, I put this in the post because it was in the paper, but there's another nerve tension test called the prone knee bend, which actually, it's funny that it's listed in the sciatica paper because it's not actually the sciatic nerve, it's the femoral nerve, which runs down the front of the thigh. So if you have symptoms or shooting pain, numbness, tingling in the front, it's usually from the upper lumbar, so the upper part of the low back. So instead of being down here, it's usually from up here. And that will cause symptoms here. And the prone knee bend looks something like this, where you're in this position and the clinician will pull this up, almost like a quad stretch, and then they will pull your leg up like this. And then to increase tension, let's say they didn't bring it on, if the clinician really wants to see if that brings on your symptoms, they can actually have your head off the table if I was laying down, and then pull my head down even further, and that would increase tension to that femoral nerve to rule it in or out. Actually, more rule it out, not actually rule it in, but it's for a cluster of tests to help figure out what's going on. So anyway, that was me talking about these tests right here. We're going to the next slide now. So now we're on to radiculopathy. So radiculopathy refers to nerve root, so basically where the nerves come out of the spine. So you can see right here, this would be the nerve coming out between two vertebrae or two bones within the spine. And if this gets inflamed or aggravated, that would be called lumbar radiculopathy. So with lumbar radiculopathy, we actually see more signs of the nerve being in more of a dysfunction state. So if someone has sensory impairment, meaning they actually have numbness, if we tap them or we prick them with a pin and there's differences between sides, then we know there's something wrong going on with the nerve, so it's affected in some way. Also, we might see weakness in the muscles that are innervated by that nerve root, or the myotome. So, for example, just like there's nerves that kind of innervate specific areas of our leg called the dermatomes, there's myotomes which affect certain muscles. So if we're talking about like upper lumbar area, like L1 and L2, which is the higher part, that would affect something like hip flexion, so bringing our leg up. So if that's weak, we know that maybe that area of the nerve or those nerves might be affected. L3 primarily works the front of the leg like the quad. So if somebody has knee buckling and their knee gives out, that one might be affected. L4 would be related to lifting my foot up. So if someone has foot drop or their foot is dragging when they walk, that might be more related to L4. L5 is my big toe. So if someone can't hold their big toe up, that might be related to the L5 nerve root dysfunction or radiculopathy. And then S1 is more related to the plantar flexors. So if someone can't push off or they can't do any calf raises with the symptoms down the leg that we're talking about, that nerve root might be affected. And then S2 would be more the hamstrings. Now, it's not like there's only one nerve per muscle group. There's a bunch of different nerves that innervate these muscle groups. But the nerves that are the primary contributors to these muscle groups are the ones that we check. That's why I kind of listed those off like that. Those are some of the muscles that we might check to see if one side is weaker than the other. And that's actually one of the hallmark signs of lumbar radiculopathy or nerve root dysfunction, is if you have weakness in specific muscles that are related to that nerve root. So that testing is really important. Now, if you've ever gone to the doctor and they've done reflexes, or they take a hammer, one of those reflex hammers, and they hit you in the tendon underneath your knee and your knee kicks up, and less often if they do it like in the Achilles or in the hamstring tendons where they tap and your foot kind of does this or your hamstrings twitch, we're testing the deep, the stretch reflex of those tendons, which can also give us information about if the nerve is not working correctly for those nerve roots of the spine. Next, we're on to spinal stenosis. So spinal stenosis is more related to narrowing of either the central canal. This is if I'm looking from the top down through the spine. This is where the spinal cord runs through the bones of the spine or the vertebrae. And if there's narrowing, like let's say as we get older, there's a little bit more bony growth. Instead of having all this extra room for the spinal cord to run through, it can get impinged. So that would be central canal stenosis, but there's also interforaminal stenosis, so narrowing on one side of the spine where the nerve root comes out. So if you look at the lumbar spine here, there's nerves that come out of the side. This would be my left side. This would be the back of the pelvis and the spine. This would be the left side of the spine. This would be the foramen where the nerves come out. Now, if this had growth in it, causing it to be less big as it used to be, that would be called interforaminal stenosis, and that can affect one side of the nerve root. This is more central, meaning it's affecting the canal itself. Usually you'll have symptoms on both sides of the legs, but it'll be asymmetric, meaning there's more on one side of the leg versus the other. It's also more aggravated by extension activity. So if people walk and stand, their spine is more in extension versus flexion, like sitting and bending forward usually help to relieve because it creates more space within not only the foramen on the side, but also within the canal, the central canal. So for example, if I'm standing for a long time, my spine is in more of an extension position. Extension meaning coming back this way. So if this is me and this is my spine, this would be more an extension coming back this way. Flexion is more coming forward or bending forward. So a lot of times people that have stenosis of their spine that's symptomatic might feel worse when they're standing for a long time, especially if they're like leaning back or if they have a large anterior tilt. They don't know how to control or posteriorly tilt out of that. Or if they're doing a lot of walking, because when you're walking, that looks like a dance move, but when you're walking, it puts your back in more of an extension position. So that can put more pressure on the nerves potentially. If there's narrowing here, if you go into more extension, that can actually put more pressure on the nerve if there's already narrowing there, as well as in the central part of the spine, the same thing can happen. Now, people that have this issue usually feel better as soon as they sit. The pain sometimes immediately goes away because their spine is in more of a flex position. So when I sit down, my spine is more usually like this, or if I bend forward, or if they put their hands on their knees, a lot of times that will just immediately take the pressure away or quickly take the pressure away. And again, to use the spine model to kind of show this, this would be the foramen. When someone bends forward or they sit down, the hole will actually get a little bit bigger. The spine doesn't actually move this much. It's not this unstable. The spine's really, really strong, but you can create a little bit more space when they do sit down. Now, this usually happens in people that are a little bit older because as you get older, that's when we usually develop arthritis or normal degenerative changes, but it causes more bony growth, and sometimes that can become an issue at times. Not all the time, but it can become an issue. Another thing that's pretty interesting about this is that many times people that have symptomatic spinal stenosis, their neurological exam is normal, so they won't have the sensory loss or the motor weakness like we talked about when we were talking about radiculopathy. Their reflexes are normal, but they have symptoms going down their legs. Here's the interesting thing that a lot of you might not know is that people that have these sciatic symptoms or radicular symptoms that go from the spine and go down the leg, just because you have those does not mean that you need imaging like X-ray or MRI. Most people don't need that. And to be honest, sometimes it can make things worse because you see these images and you see all these scary findings, or when the radiologist describes these things to you, it doesn't make sense and it gets scary and you feel like your spine is screwed up because you saw these images, and sometimes it can create a lot more harm than good. Now, if you don't improve with time, like let's say over about 6 to 8 week period, you're not really having any improvement, or if you're actually getting a lot worse, so you're getting severe or progressive neurological deficits, meaning you're starting to get a lot more numbness or weakness in your legs giving out on you, things like that, that's when we would want to actually send you in for imaging and then potentially refer you to a spinal surgeon just to kind of see if that's something that needs to be done. That is very rare though, and the majority of cases will never need to get to that point. So another cool thing to know is that when people have these symptoms in the leg, go down the leg like sciatica or radicular symptoms, it's been shown that doing non-pharmacological approaches, so basically like education and exercise, physical therapy, have shown similar outcomes to surgery. So why go through a surgery when you can just exercise and give it time and understand it better and let your body heal on its own? So surgery should always be the last resort. It should not be something that you jump at. Now, like I mentioned on the last slide, if you have symptoms lasting longer than 6 weeks and things aren't improving, you might need to see someone else to see if there's any other like medical management that could be appropriate. But again, for a majority of cases, you don't need to go to this point, especially not surgery. That should be a last case scenario. The thing that's pretty interesting is that some common surgeries that are used for this, like a laminectomy or a decompression surgery. For the laminectomy, it can shorten your symptoms, but the outcomes at 12 months are similar if you just did rehab. And surgery obviously has more increased risk, but increased risk not only of the surgery, but also risk for another surgery. So it's something that, again, you want to avoid if at all possible. It can be helpful in very rare cases, but again, it should be the last resort. And then if you guys want to know kind of what a laminectomy surgery is, I'm going to show that in a second. Well, I'm not necessarily going to show it, but the idea of a laminectomy surgery is if there is encroachment along the spinal cord, this is us looking from the top down, the surgeon takes the lamina out and it creates more room for this. But again, for the majority of cases, you do not need that. Compression surgery is similar, but what they're actually doing is they're going within the canal and they're just kind of shaving or taking out bone around the canal to make it bigger. So after all that, what do we do to help people that have sciatica or radicular symptoms in their back, in their leg, just in their leg, whatever? The first line of defense or the first line of treatment should always be providing reassurance. So I've been saying it over and over again that most people do not need surgery. You don't need to take extreme approaches. A lot of it's time, a lot of it's good education from the providers you're working with. So one of the main things that I tell people is like, you know what, this is going to get better. Majority of cases will get better no matter what you do, okay? A lot of them can become persistent, but majority of cases will become better if you stay active, if you stay positive, if you exercise, if you change the things that you're doing that are aggravating it and try to do more of the things that make it feel good. That sounds like common sense. Sometimes you need some guidance for how to do that, but that's kind of some of the key principles. Now, some people figure that out on their own. Some people need more guidance from a medical professional or a healthcare professional like a physical therapist. And some people actually do benefit from manual therapy, meaning somebody that helps kind of maybe massage the muscles or move the spine to stretch it to make it feel good. It's not 100% necessary, but some people do find, and there's been some research to show that manual therapy plus an active exercise routine and guidance and reassurance and education can be more helpful than just doing the exercise alone, so kind of a combination of both, but everybody's unique. I tend to not do too much manual therapy myself. I try to kind of put the ball in the person's court to take care of themselves and give them guidance, but it does have its place in some situations. Now, let's say somebody's not responding well to all the things I just mentioned. In that case, we might need to refer to a physician to help prescribe the appropriate medications. I'm not going to give any specifics because I'm not a medical doctor, but medications that help with nerve pain or help with inflammation, like really strong inflammatory medications like steroids, corticosteroids, not the steroids that you take to get buff, but the steroids that you take that help with an inflammatory response, and they're very, very strong. They shouldn't be taken very much, but sometimes they can kind of help calm things down so that we can start moving again and we can start going through the recovery process a little bit easier. Now, there are some cases where a spinal injection might be appropriate, but those are usually the effects that you get from those are pretty short term and they're not very big. So again, that should not be something that you're jumping to right away. That should be after you tried the other things that I mentioned, like first staying active, exercising, finding positions that feel better. And then if none of that's working, then you'd move to just oral medications. You shouldn't jump to spinal injections or surgery. Those should always be lower on the list if nothing else is working after a prolonged period of time. Now, the key clinical takeaways here, again, this post was made actually more for clinicians like myself that actually treat people with these issues, not the general population. But I've been talking to you guys. I know most of you guys aren't clinicians, so I've been talking to you in that way. But for clinicians, the key takeaways are imaging is not needed unless somebody does have serious or progressive neurological deficits like we talked about earlier. We always want to start with conservative management, so we don't want to go straight to medical management as far as like taking drugs or getting injections and things like that. We want to work on our exercise, find the things that work for us, movements and exercises that make the problem better, and also just give it time and provide reassurance along the way. And then we want to be cautious about the use of medications and injections because the risk to reward ratio, sometimes it's hard to justify the amount of risk that comes with a lot of these medications versus the reward that we get out of them. This is the last slide of the post. It kind of goes over those same clinical takeaways that I just mentioned. Please ignore the huge typo right here. But if you guys have any questions, feel free to reach out and I'll answer as many as I can.